And I will introduce. All right, so our speaker today, presenting for us all about the emergency department is Shunda Harper. Shunda is our Associate Chief Nursing Officer of Operations for our enterprise staffing pool here at Emory Healthcare. In that role, that means that she leads about 400 clinical professionals who work all throughout different Emory Healthcare facilities in women's health, procedural areas, critical care, acute care, and of course the emergency department. And she herself has over 30 years of experience working as a clinical care provider. And fun fact, is currently in pursuit of her doctorate degree in nursing administration and leadership with hopes of completing that at the end of this year. So congratulations on that, Shunda. That's really exciting. And I will pass it off to you, and we'll share my screen here to get your presentation going.
While Lindsay brings that up, thank you so much for having me. Again, my name is Shunda Harper. Happy New Year, happy Lunar New Year to each one of you. We do appreciate you for being here today. Emory Healthcare appreciates you, as do I. What I'm sharing with you today is we're always here when you need us, and that's Emory Healthcare Emergency Services. Our organization has 6 emergency departments and a sprinkling of urgent care facilities around the Metro Atlanta area. But again, like it says, we're always here when you need us. But do you ever really want to come see us? I've been an emergency nurse practicing at Emory Healthcare and DeKalb Medical for about 20 years now. Came here on a travel assignment from sunny South Florida, fell in love with the area, bought a house in DeKalb County. So not only do I work for Emory Healthcare in DeKalb County, but I actually worship, live, shop in the whole 9 in DeKalb County. I live right off Canola Road, for those of y'all that live close by. And so I'm quite familiar with the DeKalb County inner workings. But anyway, next slide, please. Like we mentioned, I'm the Associate Chief Nursing Officer for the Enterprise Staffing Pool right now. It's a recent promotion for me. However, my tried and true, my bread and butter is emergency services. I absolutely love taking care of patients in the emergency room. Most of the time, folks don't want to come see me, but they're happy to see us when they get there, and most certainly happy to get help, get relief of pain, get some answers to some questions, and this, that, and the other. Next slide, please. Well, the emergency department is, again, not necessarily where anybody wants to land, but you certainly come when you need to, and we welcome you. What constitutes an emergency? Well, most often folks liken an emergency to a new onset of chest pain or some form of trauma, something acute that recently started all of a sudden that is causing me huge concern. The number one reason people come to the emergency room is for pain. But other reasons that you might come is a sudden onset of stroke-like symptoms. And I'm gonna stop right there and we'll talk about that. So while we talk about some of these symptoms, these are leading to reasons why we would come to the emergency department versus go to your primary care doctor or stay at home and try to figure it out. And one of those is, like I mentioned, sudden onset of stroke-like symptoms. What are those? You've probably seen the billboards all over that talk about FAST. And so if you notice, you can feel it or you can see it in a coworker or a family member or a church member. A facial droop. Most of the folks just say my face doesn't look right or it doesn't feel right, or one side of my mouth might be drooping. Arm drift or leg drift, that's the A, meaning I might be right-handed, but I can't quite seem to pick that pencil up like I usually do. And it happened all of a sudden. Slurred speech is the S. I'm not speaking as clearly as I normally do. I can't enunciate. I can't say the words that I normally say as well as I usually do. Most of the time, someone else notices that, or I can't speak at all. And the T is for time to call 911. And so that's one of those reasons and one of those clinical presentations where we call 911 and let the ambulance service bring me in, because There's some treatments that could be happening on the way to the hospital. There's a call ahead to let the hospital know that you're on the way. And this is a medical emergency. Time is tissue, meaning the faster you get to us, the faster we can intervene and hopefully reverse some of those symptoms. So that's one of those times that you call 911 and come straight to the emergency department. Is presentation like stroke-like symptoms. Another, chest pain, sudden onset of chest pain. And again, I'm sure you've seen plenty of aspirin commercials explaining what it feels like, but it doesn't necessarily have to just be pain. Most of the time, our patients will tell us that it feels like an elephant is sitting on my chest. And so chest pressure, chest tightness, can't all the way catch a deep breath like I normally do. Sometimes it radiates down your left arm. Sometimes it doesn't go anywhere. Most of the time, it's different than what you're used to dealing with. Some women might complain of chin pain or what we call scapular pain in the middle of your back, right where your shoulder blades are. It shoots straight through from your chest to your back. Those are other symptoms when I should call 911. You might also notice that I'm sweating. We call that diaphoresis. I'm sweating for no apparent reason. This morning, it was about 26 degrees outside. And if I had a patient that presented to me in the emergency department that was glistening as if they were sweating, I would be concerned because that is not a temperature where one of us should have been sweating. Sometimes it's accompanied with shortness of breath or nausea. It could actually just be chest pain, but those are times that you come to the emergency department versus wait to see your primary care doctor or show up in the urgent care. Those also are times that you should call 911. And for those of us that have diabetes in the room, and I happen to be one of them, unfortunately, diabetic emergencies they run the full gamut. But the one that's most glaring to me and to my partners in the emergency department is a low blood sugar. High blood sugar is equally as important. The symptoms of low blood sugar you have to intervene very quickly. And so, like I mentioned, I live with it too. All diabetics should be carrying some form of glucose tabs or a glucagon, some way to reverse a low blood sugar. Because if you're as busy as most of us are, you take your medicine, you run out of the house, you forgot to eat, or you just didn't have time to eat. So your medicine is working, your blood sugar is going down, but we've not had any carbohydrates to help bring it back up. And so if you're having low blood sugar symptoms, unfortunately, they mimic symptoms of stroke. So sometimes somebody with a low blood sugar will start to feel as though they're having a stroke. They don't speak as well as they should. Their face may droop. Their arms and legs may drift. They may not be able to walk. Many of us can tell when it's coming or where we can intervene. Your hands shake. Your head might hurt. But you intervene and then likely call 911 if it's not reversing. But again, for my diabetic folks out in the audience, make sure you keep a source of sugar on you to avoid some of these emergencies. And if you take your medicine, make sure you eat something before you go out and about your day. So those are times that you might consider calling 911 to come into the emergency department. Bleeding. And I know you've probably heard this in prior talks. But if somebody is hemorrhaging from an acute injury, I got a cut, I was in an accident, I may have gotten stabbed, or sometimes you might encounter someone who's been shot. They're bleeding, and we have to try to stop the bleed. In order to stop it, you simply put pressure on it. Apply direct pressure, but again, protect yourself. You don't want to apply direct pressure to a bleeding wound with a bare hand, but direct pressure and call 911. 75% of hemorrhaging patients, we can save their lives by simply stopping the bleed. How do I stop it? Put pressure on it until the appropriate healthcare professionals can get there to intervene. So those are times where you might call 911 to come into the emergency department versus go to urgent care or go to your primary care doctor. Next slide, please. And so to recap what we just talked about, call 911. I'm having a sudden onset of chest pain, shortness of breath. I might have passed out. any stroke-like symptoms, and I'd like for you to make sure you understand what those are, not just for yourselves, but for people around you. Facial droop, arm or leg drift, slurred speech, it's time to call 911. Any uncontrolled bleeding, and what do we do for that? Apply pressure to make the bleeding stop and call 911. Severe onset of pain. Pain is your body telling you that something's not right and something needs to happen to make sure that nothing else is going on. And then any other concerning symptoms that you might have, particularly of sudden onset, is a reason for you to come to the emergency department. We'd be happy to take care of you. Next slide, please. Okay, you called 911 or you jumped in your car because it wasn't one of those pressing issues and you showed up. What do you feel like? Do you feel like she looks? I got to tell you, as an emergency nurse, you look like she feels because I've seen you. Anxious, scared, fearful, and you don't know what's going on. Sometimes you don't know what to expect, and you don't know what to tell the hundreds of people that are texting and calling you to find out if you're okay. But we're here to help. We're here to take care of you. Next slide. So once you come in, you check in, and it doesn't matter which way you come in, by ambulance or by private vehicle. Triage. Triage is a French word that simply means sorting. At triage, you check in, give us some demographic information, your name, your date of birth. Sometimes you might have to type in your social security number so that we make sure we have the right patient. And you'll meet a registrar, a nurse, and possibly a tech, and maybe even a provider. Most of us at Emory Healthcare have a provider at triage. So there's a doctor or a PA or a nurse practitioner up front with the nurse so that we can get your treatment plan underway. At triage, you get your vital signs taken. We'll ask you about your history and what brought you to the emergency department. What was concerning that brought you in? From triage, we will order some diagnostic exams if they're warranted. That way we can go ahead and get x-rays ordered so we can get those started. You might get an EKG pretty quickly if you're having chest pain or chest discomfort. You may get a breathing treatment if you have asthma and you're wheezing, but those diagnostic exams actually start on arrival. What else starts on arrival? The plan for discharge. As soon as you check in, we start the plan of A, figuring out what's going on, B, how do we intervene, and C, what happens next. And that's where some of your anxiety may come, is when you don't understand what happens next. It's okay if you ask questions, but we should volunteer what we're going to do. I'm going to do an EKG and I'm going to show it to the doctor. Based on the findings from that EKG, we'll move forward thereafter. We might actually draw labs, and that's what really freaks everybody out, is that they have to get blood drawn. I got to get stuck. You have to stick me. Do you really have to stick me? Yes. Most often we do. Lab is our #1 diagnostic, and your blood work oftentimes tells me what's going on. There's an oscillerism. Dr. Osler is a physician from, I believe it's Germany, and he has frequent oscillerisms, and I use this one often. If you listen to your patient, they'll tell you their diagnosis. And so simply listening to you tell me what worried you enough to come to the emergency department, most often we can come up with what's going on with you. So an example is, I have a younger woman and she came in complaining of, she said, chest pain. I simply asked her, point to where it hurts. Well, she pointed to what we call epigastric. It's right where your ribs meet in the center of your chest. And she says that every time she drinks milk, she starts to get nausea, she throws up, she has excruciating pain, she thinks that she's having a heart attack. And so I simply ask, first, let's get an EKG, because that's the most pressing. But second, you notice this after you drink milk. Is it full fat milk or is it skim milk? And she says, oh no, I can't drink skim milk. It's awful. So it's full fat milk. Have you ever had any surgeries in the past? No. So that means you still have your gallbladder. Yes, yes, I do. Okay. So we rule out the medical emergency to make sure that this is not cardiac, because where she points, there's some body parts, namely your heart, that sits right there. But there's also a gallbladder right there. And based on the symptoms that she's describing to me, it sounds like it might actually be a gallbladder that's her problem. And so we run tests going in both directions. For chest pain or anything cardiac, is she possibly having a heart attack, or is she having a gallbladder flare? Fortunately, but unfortunately for her, she had to go to surgery because it was actually her gallbladder, and we've seen it so many times. But based on what my patient tells me, we know what to order, where you might be going, and believe it or not, we know if you're likely going to be admitted or discharged home from the first conversation you have with us. Once you start to get some of your results, it takes about 90 minutes to start get lab results. And from the time that you have any radiologic studies, any x-rays, CAT scans, MRIs, it takes about 90 minutes for the radiologist to read those tests. We start to get results, and we can develop the plan on whether or not you need to stay in the hospital for a day or so until we can do some more work to get you feeling better. Or can you go home and follow up with your primary care doctor or any specialist that we refer you to? The follow-up is incredibly important, and having a primary care doctor with whom you have a relationship is even more so important. Next slide. So the patient experience, we've already talked about what you look like and what you feel like when you get to the emergency department, how anxiety producing this can be, how scared most of you are. And then you have a complete stranger in Shunda asking you all of your personal information. I know your date of birth, the last 4 of your social, how many kids you had, your last menstrual cycle. In about a 10-minute conversation, you've had to share all of that with me. And you've never seen me before, and it's likely you'll never see me again after today. And can that make you anxious? Yeah, it actually made me anxious just talking about it. But we try to stay patient-centered, try to understand what it feels like to have been that person. Believe it or not, as much as I do this for a living, when I'm not well, I am a patient. And man, am I probably the worst patient. I know just enough to be dangerous. But we want to keep you involved in the decision-making as well. In that perfect state, we've talked about what we want to do and allowed you to share some feedback on what you'd like to see happen as well. Keeping patients updated or informed, I'm letting you know what tests I'm going to run or I plan to run. I'm asking you more questions, letting you and your family play a part in the decisions that impact you. Actually helps reduces our patients' anxiety and fear about being in the emergency department. And every so often, you might actually see one of us. Not only am I an emergency nurse, but I'm an emergency nurse leader. So it can be anxiety reducing to actually see the charge nurse or the manager, or like me, the chief nurse, come by every now and then just to say hello and speak to a few of our patients every day. Next slide. But no presentation would be complete without some mention of COVID-19. It's been sprinkled through all of our conversations for about 3 years now. And it's played a major role in how emergency departments, healthcare facilities, even the grocery store, how each one of us functions in those arenas now. COVID-19 had a huge effect on us. For one, at first, it was what we didn't know. We too were learning as fast as our patients in our communities were learning. And we too were anxious and a bit fearful sometimes. We too were getting sick and exposed as well. And so with every PPE shortage, and that's our personal protective equipment, for every time a guideline changed, we had to stop on a dime and switch gears. Well, that's what emergency nurses and doctors do, and we do it well. But when you compound it with we're sick too, we're getting exposed too, it increased the anxiety exponentially. But have we been making it through it? We most certainly have. So there's been times where we had to set up the tent because we had so many patients running out of the emergency department that we needed more space. And then there's times where that was probably the fastest trip I've ever made from my house to Emory, Decatur to get to work, because there was nobody else on the expressway. Everybody was staying at home. Everybody was staying away from each other. But as an emergency nurse, I certainly did not have that luxury, and I didn't want it either. I wanted to be able to provide a service to my community and take care of my patients. And so while everyone else was sheltering in place, most of us were still coming to work to be able to take care of our sick patients. We now have all the PPE we need. We have vaccines and boosters and the whole nine so that we can do what we can to keep COVID-19 at bay. If you ask me if I think we'll ever go back to pre-COVID emergency services, I don't think we will. I'm optimistically hopeful that we will continue to move forward and keep impacting and saving lives on a daily basis. Some stuff I don't want to go back to where it was. I like the fact that I see hand sanitizer all over the place. Now I'd like to see more of us use it. I like the fact that we're keeping a little bit of distance, but I also like the fact that we're now able to be back amongst each other safely and without making each other ill. And so I'm a people person. I love being around folks. So that shelter in place, I was happy to be able to go to work despite the fact that it was at the height of COVID, because I could get to see my patients, see my family members, see my coworkers, and to be around them. Next slide. And so I know I've shared quite a bit of information about what you should expect when you go to the emergency department, when you should call 911. Last bit of information I'd like to share with you is usually when you're as anxious as you are when you come to the emergency room, your mind isn't all the way where it should be, and you might forget some of the information that we need. We expect that. We expect that as through the course of your visit, you'll start to remember more things about your symptoms or what brought it on or what makes it better. What I'd encourage you to do is keep a list of your medical history, any medications you take, any surgeries you've had. Most of us have that on our phone. You can keep it in the notes on your phone, but have it in a place that you can either grab it. And I've not seen a patient lately that didn't have a cell phone when they came into the ED, so that you have that information readily available for us, or any phone numbers that we might need to call or anybody we might be able to get in contact with. So grab your phone, keep your information updated somewhere in your notes or in your phone so that you have it when you come to see me. It helps me help you out a whole lot better. Thank you so much. What questions do you have for me?
Thank you so much, Shunda. So yeah, the floor is open for questions. You all are welcome to use the question and answer tool at the bottom, as well as the chat feature that's enabled so that anyone can type in there if they like. And as well, I've just given all attendees the ability to mute or unmute themselves if they'd like to speak out loud and ask a question. So we'll give folks a few seconds here to see if anyone has anything initially. And I know if not, I have a few questions I would ask. All right, so Shunda, I'll check on the chat and everything for you. So we have a question that came through that says, if possible, if a patient has pain in their chest, can they go to urgent care because finances tell them to?
I certainly understand that part, and hospital visits, emergency visits can be quite expensive. What I would challenge you to do is, if you do choose to go to urgent care, I got to tell you, more often than not, as soon as you tell them the symptom that you're having, they're either going to send you to the emergency department, or they might actually do an EKG, and based on those findings, they might refer you to go on your own. Typically, it depends on how the patient presents, but time is of the essence when I have a patient having chest pain. And years ago, it used to be that anybody 35 and up with significant medical history, but that's not always the case. And so again, pain is telling. It's telling us that something's going on that we need to address or we need to investigate. Chest pain is more telling. And the reason I say time is of the essence is, if in fact you are having, you'll hear us say MI or myocardial infarction. Those are big fancy words for heart attack. The EKG, just some of those little lines on that paper, are clear to me if you're having a heart attack. And then I can activate my cath lab or my interventional cardiologist, the folks that are going to fix it. I activate them. And within 90 minutes or less, my team is here. My patient is in the cath lab. They've been cannulated, is what we call it. And they are looking into the vessels of the heart to open back up that blockage. If you're in the emergency department, we can do that in 90 minutes or less. If you're not, it takes more time. And as that time transpires, more and more of your heart muscle is being impacted. And so that's why we ask that if you're having chest pain, just come to the emergency room. If we do an EKG and there's not a whole lot going on, or it's not reflective of a heart attack, then we can switch course and go in the other direction. I understand the finances piece. Like I said, I know that those visits to the emergency room can be quite expensive, but I would challenge you to put your health first and give me and my teammates the opportunity to do right by you as quickly as we can. You're welcome, Vanessa.
Shunda, I guess just kind of one thing that just popped into my head in terms of, urgent care versus the emergency department is, could you just give a few examples off the top of your head of things that, would be, I guess, okay and acceptable to go to an urgent care for instead of the ED?
Sure. One of my colleagues just had it happen this morning. He woke up with a little bit of a fever, otherwise fine, had a slight cough. He tested himself and tested negative for COVID, but still wasn't feeling as well as he should be, and was trying to decide if we have a big meeting tomorrow morning, should he be around us? Of course, my answer was no, I don't care what your test said, you shouldn't be around us. However, he scurried on over to urgent care. They swabbed him and he's actually flu positive. So based on his symptoms, he wasn't having shortness of breath. Fever wasn't causing chills, but he checked his temperature. That was safe to go to urgent care. I'm a former athlete, although I still am professed as a basketball player, but I'm 53 years old and I don't think that I'm going to be in the NBA anytime soon. And so playing my grandkids, playing some basketball, I zigged when I should have zagged and rolled my right ankle out. I could almost tell that it might not have been fractured. It didn't feel like it was, but I eased over to urgent care instead. Did call my primary care doctor because, like I said, I have diabetes. I can't be too careful. And what he suggested was to go over to urgent care. They did a quick x-ray, didn't have a fracture, wrapped it up. And I was able to play basketball about three weeks later with my 7-year-old grandson. So sometimes orthopedic injuries, you can go to urgent care about those. Some gastrointestinal issues, I'm having horrible cramps, don't know what's going on, but I'm not short of breath, I'm not having chest pain, I'm not bleeding, and I'm not throwing up. So let me just go see if they can take a look. Sometimes the urgent care can point you in the right direction.
So another question that I kind of have here that I know sometimes is common while other people maybe ponder on some questions. So I guess the first one is it true or is it a myth that you'll get seen and you'll get to the back and get taken care of quicker in the emergency department if you come in by ambulance versus coming in by yourself?
That is an excellent question, and thank you to whomever asked, all of them in particular, but this one. It is true that we see sickest patient first. And so what you'll find in the emergency department, it is not first come, first serve. It is sickest patient first. And so if I come in by ambulance, but the one that came in through the front door has an issue that is a lot more pressing, it's a lot more time sensitive, and if I don't act immediately, this person is going to lose life or limb. It doesn't matter how they came into the emergency department, that patient is next. That one is my primary focus. So just for example, if I've had a patient come in that is diaphoretic, the one that's sweating for no apparent reason, complaining of chest pain and shortness of breath, but his wife dropped him off at the front door and he barely made it in. However, I had what could potentially be a sprained or fractured ankle that came in by 911. Well, my patient that came in through the front door with the chest pain, shortness of breath, diaphoresis is the patient that I have to focus on first. That doesn't say that we negate the chief complaint of either patient, but based on our training and our experience, we make decisions, clinical decisions, all day, every day on who's next. And it's always sickest patient first.
Hi, Lindsay. This is Andrea. May I say something for just a moment?
Yeah, go for it.
We had the employee earlier that was asking about seeking medical attention, and the issue of finance came up. While of course, we all, look at our finances when we're making decisions. I want to make sure that the employees that are on the call who are enrolled in state health benefit plan realize that they can earn wellness dollars. And depending on which plan they're in, if they're in Blue Cross Blue Shield or Anthem, if they have single coverage, they can earn up to $480. If they have single coverage, $960. If they have a spouse that's covered, if you don't use that year to year, it rolls over. So sometimes just having that little cushion, earning those dollars and having that little cushion can help you and kind of ease the burden of the medical expenses. So if you're not familiar with the earning the wellness dollars, please send me an email and I will send you that information. But please make sure that you're earning those dollars, because it can definitely help offset the cost of some of your medical expenses, be it a prescription or be it a visit to the emergency department. Just wanted to make sure that everyone was aware of that.
Thank you so much, Andrea. That's great.
You're welcome. And the address for those of you that are on the chat, my email address, I've placed that in the chat as well.
All right. So does anybody, Shunda, I had another question for you, but you kind of answered it in my one before, in terms of, I was going to say, why is it that if I might be sitting in the waiting room, I might see that people who come in after me get seen before me. But you answered that already.
That's why I thought I mentioned that was an excellent question, because as the nurse leader, oftentimes when I've been making rounds, I don't know many days that go by as I'm rounding that somebody doesn't ask me that question. We actually have specific signage that speaks to that, but we're real people too. I understand when I don't feel well, none of that makes sense to me. I just want some help, and I understand.
So another question is, are there kind of standard busier times of the week in the emergency department? So, is it are there more ideal times to come, less ideal times to come? What are your thoughts on that?
Well, quiet as it's kept, there's never an ideal time to come to the emergency room, because clearly you don't feel well. Something's wrong, and we don't want anything to be wrong. However, I've been an emergency nurse for 20 years, and we look at data so that we know how to make changes. Do we need more staff on this day? Do we need more staff on these hours? And that's how we govern what time of day our folks come in. Mondays are hands down across the country the busiest day in the emergency department. Why? Well, I got some answers, and these are anecdotal per Shunda. However, why? Because the doctor's offices are not open on the weekends. Some actually have started having Saturday hours, and with the increase in urgent cares that are open 7 days a week, we've seen our Monday volume drop off just a little bit, but not by much. Reason why Mondays are typically our highest volume days is because I've probably not been feeling well since Friday evening, but didn't necessarily know where I should go. And so everything was closed. Doctor's office was closed. On Monday, I'm coming in so somebody can tell me what's going on. Mondays are again, hands down, our busiest days in all of our emergency departments. And so we govern our staffing grids accordingly. Coincidentally, for the 2 emergency departments that I've led with the DeKalb operating unit, for some reason on Thursdays, particularly Thursday evenings, we had a lot more trauma. And I don't understand that for the life of me. And I've been trying to put my finger on it. We used to joke that no, Thursday's not ladies' night. Thursday's not Bible study night. Why? What is going on with Thursday nights? You would think that it would be Friday night or Saturday night, But for us, it was Thursday night. If anybody can figure that one out, let me know.
I was gonna say, is that, maybe part of your research and your doctorate program right now?
Well, coincidentally, my project is on decreasing workplace violence.
There you go. So it looks like we've had a few more questions come up. So the next one that we have for you is, what is cardiac arrest versus a heart attack?
We'll go with the lesser of the two if there's such a thing. A heart attack is there's a blockage, or the blood flow to the heart muscle itself has been stopped or impeded. And so if you have, for those of the team that have like high cholesterol or high blood pressure, it puts a lot of stress on the teeny tiny vessels in the chest, particularly in the heart. And so if you get any blockage or narrowing where we can't get blood flow, and blood carries oxygen to the furthest parts of the heart muscle, you start to have that chest pain, and it's letting us know that there's a blockage somewhere that we need to go open back up or fix as fast as we can. Do you still have a pulse with a heart attack? Most often, yes. Are you still breathing with a heart attack? Yes, you are, because you had to be breathing with a pulse to tell me that you were having chest pain. Can a heart attack lead to cardiac arrest? Yes, it can, if the blockage is so big or that there's not intervention as quickly as it should be. So I say lead to cardiac arrest. Cardiac arrest is my heart stopped. It's not beating anymore. It's not pumping oxygenated blood to the rest of my heart, particularly the rest of my body, my lungs, my brain, that tell me to breathe, tell me what to do, tell my heart when to beat. So in essence, my heart has stopped. And we liken that to, I've stopped breathing. So sometimes my heart will stop, but I might breathe a few more times, or I might not be breathing, but my heart's still pumping. Well, myself and my team, we've all been trained to recognize one versus the other or both and intervene appropriately. If you're not breathing effectively, we breathe for you, meaning you might have heard or seen on TV or seen in real life where we call it bagging. There's a big bubble of a plastic brouhaha, and we put it over your face and we hook it to oxygen and we squeeze it. Every 6 seconds we squeeze it. We're actually putting oxygen into your lungs. What if my heart's not beating? Well, you've seen it on TV, I'm sure, and you may have seen it in real life where one of us is doing what we call chest compressions. We've all, again, been trained specifically, and we get far more practice than we want on how to do appropriate and effective chest compressions. But at the same time, when you're in cardiac arrest, there's medicines that we can put in your body, in your vein, to try to help is similar to jump starting your heart. It's giving you medicines that will help your heart to restart on its own. I'll do it for you until you can do it on your own. And so cardiac arrest is my heart stopped or I stopped breathing. And so now we intervene to help you. We do it for you. We pump your chest. We do chest compressions, or we put you on the ventilator or the respirator is what some folks call it. So the machine breathes for you. But a heart attack, I am likely still awake, alert, with a pulse. I'm breathing. I can talk to you and tell you what's going on with me so that you can get me to where I need to be to get it fixed.
Awesome. Thank you so much for clarifying. Another question we have here is, speaking of COVID, your one slide that you had before, how likely, is someone, or am I, to pick up COVID or something else or the flu while I'm in the, emergency department? Like, am I going to be safe in the waiting room, basically?
Well, fortunately, Emory Healthcare still has the masking procedures. We still have our routine cleaning guidelines that we've always had, but we really honestly kicked everything into high gear, and it's going to stay there. You are far more likely to contract not just COVID or the flu, but any infectious disease process in your regular run-of-the-mill day. As you go to the grocery store, you'll encounter a whole lot more people, the grocery cart, the doorknob, your cell phone, things of that nature carry microorganisms that we might not even pay much attention to. And once I touch it and touch myself in the face, in essence, I just infected myself. And so is it impossible to get exposed in the emergency room? It's not impossible to get exposed anywhere, but you are far more likely to get exposed in your regular run of the day. What I would challenge you to do is to make sure you keep your distance, wash your hands as often and as frequently as you can, and get your vaccination if you're not opposed to it. I am a vaccination kind of girl. Again, I mentioned I have diabetes. I am a 53-year-old Black woman with a healthcare issue. According to the literature, I am the one, and if you look anything like me, you are the one that will contract some infectious disease process and not have a good outcome. And so let's set ourselves up for success. We're going to keep our distance. We're going to stay masked when we should be, or when we're in enclosed areas around other people. We're going to get our vaccines. If you're not opposed to it, we'll keep our hands cleaned up. Hope I answered that question.
You did, thank you. All right, so we'll give folks another second or two to see if any more questions come through. Let me stop sharing. Again, feel free to use the chat, the question and answer, unmute yourselves if you have any last minute questions. If not, we will be sharing this presentation as well as the recording afterwards, so keep an eye out for that. And just a little shameless promotion for some of our other upcoming presentations we have for you all for the rest of the year. Working on coordinating some different speakers on hopefully the topic of caregiving, some stroke education and prevention. So that'll kind of tie nicely into Shunda's presentation here. Also possibly a presentation on some medication management and kind of what to do if you see an overdose. So some really interesting topics we're going to have for the rest of the school year. So keep your eye out for those notifications and flyers. Again, just wanted to thank everyone for joining us today. Shunda, thank you so much for your not only insightful presentation, but also, I guess, just personally for myself, being a patient and a community member, for working in our emergency departments. You know, it's a place I don't think anyone ever wants to have to end up. But, you know, when we do, I know people are very thankful that teams like yours are there. So yeah, just wanted to wrap up. Again, if anyone else has any other final questions, comments, remarks, if not, we will let you all go and enjoy the rest of your day.
Thank you so much for having me.
All right. Thank you, everyone. Have a good day.